Hello and welcome to Rehab Reels, conversations on physical medicine and rehabilitation, hosted by Dr. Gwen Soa. Our featured guest this evening is Dr. Christine Paul. Dr. Paul is an assistant clinical professor and the clinical director for the Division of Inpatient Rehabilitation Psychology and Neuropsychology Services. She completed her doctoral degree in clinical psychology with a specialization in multiculturalism and diversity from John F. Kennedy University, California. Dr. Paul completed her postdoctoral fellowship at Rancho Los Amigos National Rehabilitation Center and is board certified in rehabilitation psychology by the American Board of Professional Psychology. She has clinical expertise with various rehabilitation populations, including adults and older adults with spinal cord injuries, acquired and traumatic brain injury, amputation, medical complexities and burns, providing inpatient rehabilitation psychology and neuropsychology services to patients at UPMC Mercy Rehabilitation Institute and UPMC Mercy Hospital Trauma Service. Dr. Paul is engaged in various clinical research opportunities within the department. Her clinical areas of interest include post-stroke depression, cognitive behavioral therapies, mindfulness-based therapy approaches, cultural diversity, wellness, sexuality and disability, ethics, and substance abuse. In addition to her role in the department, Dr. Paul serves on the board of directors as the mentor chair for the American Board of Professional Psychology Rehabilitation Psychology Specialty. Dr. Soa and Dr. Paul, thank you so much for being with us today. Dr. Soa, the floor is yours.
Thank you so much, Andy, and thanks to Dr. Paul for being here with us today, and welcome back to some of you, and welcome to some of our new listeners as well today. I think you're in for a special treat with Dr. Paul. So as you heard from her bio, she's had an amazing impact both locally and nationally in the field. But what you wouldn't have heard from her bio is what an amazing resource that she is for our faculty, our staff, and our community in general, in addition to the patients that we serve here. Today's another great example of that, and I think you'll hear a little bit about that. And the topic of resilience and coping is certainly a hot topic in rehabilitation, and it's obviously an important topic even more than ever based on the last 2 years and what we've all experienced. Dr. Paul's approach is actionable. It's things that we can all incorporate. And as we continue to think about the care of our patients, the training of our trainees, these are such important topics. And Dr. Paul brings an incredible voice for this topic. And I'm so thrilled to share this with you today. So we look forward to her presentation. Dr. Paul, please.
So as mentioned, the topic today that I'll speak about is rehabilitation and mental health, coping with disability. As Andy mentioned, I do provide services on the inpatient units at Mercy, particularly at this time with individuals with acquired disabilities. And I bring that up because that will be my focus for today. So when we talk about coping with disability, it's a very broad term. And for the purpose of this presentation, what I'm going to do is define a little bit about our role in rehabilitation psychology and the guiding principles we have. I am going to talk about adaptation and adjustment to a new acquired disability. That means a sudden new chronic illness or a new traumatic event that results in disability and what we know. I do want to speak more about families and adjustment to disability. As Dr. Soa mentioned, I will talk about the role of resilience and post-traumatic growth. And then I'm going to tap on a little bit about some of the treatments and coping strategies. So just for you who may not know what we do, rehabilitation psychology is a specialty area within psychology that focuses on the study and application of psychological knowledge and skills on behalf of individuals with disabilities and chronic health conditions in order to maximize health and welfare, independence and choice, functional abilities, and social role participation across the lifespan. You not only find us in clinical practice, but you also find us in research and public policy and advocacy. This is a little bit different from neuropsychology, but they work well together. Neuropsychology really is a branch of clinical psychology that focuses on the study of brain behavior relationships and that clinical application of knowledge to human problems. So the best way I can frame it, and what I've stated to others, is that practicing neuropsychology, getting an idea of what kind of cognitive changes there might be in an individual, tells me what's going on, but the rehabilitation psychology piece is what now? What can we do with that information? How can I make that into more meaningful recommendations to give to the patient, family, and to the team to help maximize adaptation and recovery? Just to give you a brief history of rehabilitation psychology, I would say that contemporary rehabilitation psychology was really widely considered to have developed in the 1940s and 50s. And really what you had is around that time, at the end of World War II, you had a lot of veterans coming back with multiple medical conditions, including, excuse me, traumatic brain injuries. And this pushed the need for comprehensive clinical care and interdisciplinary care. Some of you on this call may already know about Dr. Rusk, who people consider the founder, who was an Army physician and started to make a more holistic approach at that time, not just physicians, but including psychologists, physical therapists, occupational therapists, and activities therapists. Also in the 1950s, you see legal actions being taken. This is where the birth of vocational rehab starts. And now you see laws passed where it makes it a requirement to offer vocational services for both combat and non-combat veterans. Our division of rehabilitation psychology was started in 1958, and it wasn't until 1990 that we had more specific training parameters for practice and education, which kind of coincides with the 1990 American Disabilities Act as well. And our board specialty certification was started in 1995. So this is a little bit about some of the populations we serve, not only brain injury, spinal cord injury, but also chronic pain, sensory impairments, burns. And you find us in a wide variety of settings, not only in PM&R departments, but psychiatry, neurology, on the critical care units, post-acute, subacute, even in forensic settings and prisons. Now, when we talk about some of the work that myself and my colleagues do, there are some guiding principles we use. Dr. Beatrice Wright was the founder that created 20 core principles. And like I said, this guides our theory, development, and guides my clinical practice. I've listed here, this is a pretty busy screen, but this is a list of our guiding principles. I'm not going to go into detail of each one, but I do want to read just a few because it will come up later as I talk about resiliency and even treatments and coping strategies. But one, the issue of coping and adjustment to a disability cannot be validly considered without examining the reality problems in the social and physical environment. Another, the assets or strengths of a person must receive considerable attention in the rehabilitation effort, and that persons with disabilities should be called upon to serve as co-planners, co-evaluators, and consultants to others, including professional persons. These principles have been examined and improved over time to 6 core principles. Now, I just want to take a few moments now to just do a brief exercise. I just want you to sit back and think for a moment. When you think of the term disability and mental health, what comes to your mind? What do you imagine? Or maybe who do you imagine? Do you imagine people that are younger or older? What might their capabilities be or their functional limitations? And more importantly, what emotions do you sense they might have, or what emotions come up for you when you think of this term? I bring this up because more often a lot of individuals will tell me what comes up for them is more of the negative emotions or maladaptive problems. And I do acknowledge our literature in our field has focused a lot on those maladaptive problems, but there is a whole area that's emerging more on the resiliency and the positive adaptation and growth from disability. This is just a little bit on mental health and disability, just what we know, some statistics. And this one's from the CDC, we know that adults with disabilities report experiencing frequent mental distress almost 5 times as often as adults without disabilities. And in this case, frequent mental distress is defined as 14 or more self-reported mentally unhealthy days in the past 30 days. They do find it is more commonly reported in females who are unmarried, and maybe those that identify as gay, lesbian, bisexual, and live in lower income housing versus males who are married, employed, straight, and have higher income. And there is higher rates in those who identify as non-Hispanic, white, and younger. And like I said, this is another slide on just some statistics, but I hope you get the sense of what I'm saying is that, you know, the rates of individuals who are diagnosed or report mental distress or even diagnosed with mental health conditions is higher in folks in the rehab population. So why am I making such a big focus? The reality is that depression in particular and some of the other mental health conditions is associated with poor outcomes. When I meet with patients and families on the rehab unit, one of the things I try to explain when I introduce myself is that as a team, we understand we're not only focusing on the medical or physical aspects, but the emotional and or spiritual part is part of you too. And what we find, if one's not working, the others can get affected. And so depression is one of the strongest of factors affecting ADLs. If you think about it, if someone might be experiencing moderate to severe depression or even high levels of anxiety, it can be harder to participate in therapies, and therefore it can affect the outcomes. We do know that there is higher rates of mortality in rehab populations with those who are diagnosed with depression, increased utilization of healthcare, and really just understanding the prevalence can help mental health professionals like myself learn about target interventions and healthcare screening and support and care. And of course, I cannot talk about coping with disability without bringing up the COVID-19 pandemic. So when COVID hit, one of the things we did in our field of psychology is we looked towards the literature of what we knew about mass trauma, so such as flu outbreaks and natural disasters. And really what it suggested is that pandemics might particularly harm the mental health of marginalized populations who have less access to socioeconomic resources and supportive networks. What it also showed is that research on past pandemics reveal disabled people can find it harder to access critical medical supplies. And of course, there's a sense of increased isolation, disrupted routines for everybody, and perhaps diminished health services. This is some of the latest research coming out towards the end of last year, but what you see is what we found, what we've known with mass traumas, particularly with spinal cord injury populations, noting negative impact on mental health, concern of rationing care, and perceived stress. Now let's talk a little bit about adjustment to disability. I always say when talking about adjustment to disability, we always have to put it in context. Often when we're looking at assessment, we're focusing on the biological, psychological, and social effects. Another way to look at it too is the International Classification of Functioning Disability and Health. And what you see here is they focus on biopsychosocial effects. So what that means is that when we're completing our assessments, these are some of the things we might be looking for or assessing. Pain, emotional factors, fatigue, sleep, coping strategies, sexual functioning, parenting, and characteristics and behaviors of family and community members. Now, when I talk about adjustment to disability, if there's anything to know, it's that really coping with a disability or chronic illness is an ongoing dynamic process, one dependent on making constructive changes to the social and physical environment. It is challenging to reconstruct your world all of a sudden. And adaptation, or the end result of adjustment, could be positive or not positive. I do want to be specific with the language I use here when I talk about coping with disability. There are a lot of different models, excuse me, for coping with disability. But I'm just going to talk about some common themes and one theory here. Again, putting in context, when an individual has a new sudden chronic illness diagnosed or an acquired traumatic injury, there is a period of adapting. So in this sense, adaptation really is how people with acquired disabilities understand and how the psychological and physical changes are gradually integrated into their identities, body images, and daily life. If you put it in this perspective, it means that it's also an active physical, somatic, psychological process experienced by those with acute disabilities as they move towards an idealized state known as adjustment. So in this case, if you frame it, a person goes through a process of adapting, and the end result, the finalized result, would be the adjustment. I also want to talk a little bit about acceptance. Acceptance of a disability occurs when the disability or chronic illness becomes a part of a person's self-concept. It is incorporated when we talk about coping with disability, and it doesn't mean you're throwing in the towel or giving up. It really is when disability is viewed as non-devaluing, meaning it doesn't reduce your self-worth anymore, or future opportunities or potential, or the general psychosocial performance. And it really is marked by perspective. Here are just some qualities demonstrating psychosocial adjustment to disability, or a positive one, if you want to look at it. You know, things like possessing a sense of personal mastery, acceptance, presence of a positive self-concept and self-esteem, an independent attitude, and accommodation. Now I want to talk briefly about families and coping with disability. You know, often I will tell families, and particularly I say this because, as I mentioned, I work with individuals with acquired brain injury, so often they do present with cognitive impairments, but you know, this is not just something a patient or the person with a disability goes through. It ends up being a family issue. And that person with a disability may not remember every detail of what's happened if it's a traumatic event, but the family members remember every detail. And often we forget to ask how they are doing and coping. So let's just try to look at it from their perspective. So these next couple of slides I'll bring up about how changes affect families. If you notice, I'll read some of them, but these are often the changes that the person with the disability would experience too. That changes in family roles, relationship roles, social roles, quality of life decisions, issues of independence, dependence. With families in particular, there's the issue of the caregiver role and the areas of impact. And the reactions to injury, again, this is similar to what a person with a disability might experience, particularly the ones I work with on inpatient rehab, but emotional, cognitive, behavioral, and physical health. In looking at it, we do know that families adjust in different stages. And this is a little bit more in particular about the patients I work with, but patients and families, what I do know is that often in the acute phase, family members may have a sense of numbness, or they might be in crisis mode, so to speak. In inpatient rehabilitation, that sense of numbness may wear off, and sometimes there's more emotions that arise. There's often questions about what's temporary versus permanent. There's emotions of anxiety, fear, and depression that start to emerge. There's even times when family members may not agree on care. I had a patient recently on the unit who had a metastatic brain tumor diagnosis. And what was very challenging for me and the team was the fact that, you know, and this is a strength too, she has a lot of family members, but the two particular who were her POAs had very different ideas of what to do with her care and what to do after she left here too. Lucky for that patient, she did have capacity so she can make her decisions of what she wanted with her care. If patients do end up going to a skilled nursing facility, often what we find is family members are still maybe protected from the full brunt of responsibility, and maybe more emotions can start to increase or continue as they plan for transition home. And or if the patient goes home, they often do need consistent supervision, depending on the diagnosis, and they need physical assistance. And we do ask a lot of our families. And often, depending on the disability, we ask them to prepare for long-term care as well. So some of the qualities of adjustment we see in families is, again, similar to the person with a disability. And factors that can affect a family's ability to adapt. Some of it include pre-injury functioning and cohesiveness, attitudes towards illness and disability. I usually say ability and willingness to care for the individual with disability, and economic and social supports. And some of this are indicators of what we consider a strong or cohesive family, willingness to compromise, spirituality, ability to understand, willingness to take care of themselves and provide a sense of belonging. Now I want to talk a little bit about resiliency and post-traumatic growth. So resiliency, as Dr. Soa mentioned, it's been quite popular in the field, and I want to say even more since pandemic too. And I would say there's obvious application to the field. As I mentioned, we help individuals with disabilities learn to cope and adjust after acute trauma or chronic illness. I think the tough thing about resiliency from the researcher's perspective, though, is that even though we have many different models of resiliency in our rehab populations, there is no real universal definition of the term, which can result in differences when we try to identify some key factors that construct resilience. Some of the researchers I've read have commented that resilience is trait-like versus, which I would believe, more behaviors, thoughts, and actions learned over time. One definition I've seen is healthy psychological functioning in the face of adversity. Another definition I've seen is an internal motivational force that drives you to seek wisdom, self-actualization, or even the ability to bounce back from adversity. There are some common themes, though, that we see in these definitions, which I'm happy to talk about later, but psychological and dispositional attributes, family support and cohesion, and external support groups. What we do know about resiliency is that it does improve psychosocial outcomes when we talk about quality of life for several rehab populations. This is just one in particular with spinal cord injury, and we talk about protective factors, including coping skills, self-efficacy or the belief you can do it, optimism, spirituality, less pain interference, and functional independence. Now, post-traumatic growth is a different term, though sometimes you might hear post-traumatic growth and resiliency used interchangeably, but they are different. I do believe post-traumatic growth has also been out in the field more. I've seen more articles, at least when we talk about the COVID pandemic and post-traumatic growth, particularly with healthcare workers. But in our field of rehabilitation psychology, it's still less well known. It actually wasn't developed until the 1990s. But we do have some research in it, it's still emerging. But really what it means is that people who endure psychological struggle following adversity can often see positive growth afterwards. So I challenge, individuals who might be on this call, are there any positives if you've experienced a disability or if you're a caregiver or a spouse of someone with a disability? For anyone on the call, are there any pandemic positives? There's another part of our field too called positive psychology. And this ties in a little bit with post-traumatic growth, but greater attention is being made to measuring positive indicators and quality of life in positive psychology. So what does post-traumatic growth look like? It is a deep change. It's a new appreciation of life. It's not a return to baseline. Personal strength, growth in relationship with others, and a spiritual change. And this slide just talks a little bit about the differences. Again, resiliency is the ability to bounce back from adversity. And post-traumatic growth, again, is those who see positive growth afterwards. There are some people who have high levels of resiliency and may not have post-traumatic growth because they may not see the event as traumatic. There are some people that experience both resiliency and post-traumatic growth. But like I stated, the changes are powerful. Another emerging field topic I want to bring up is disability identity. Disability identity is a unique phenomenon, and it shapes a person's way of seeing themselves, their body image, and their interactions with others in the community. And here are just 6 key themes we've seen in disability identity that I hope to see more research and we can utilize in clinical practice in the future. Now I want to talk a little bit about some coping strategies. So I give the disclaimer, of course, as you know, I'm not a physician, I'm not a physical therapist, so please consult with your doctor if you're an individual with disability and you're interested in physical activity and exercise. It's just one thing I want to point out is that our guidelines from the American Psychological Association on complementary and alternative treatments list the option of exercise monotherapy for adults more with moderate to severe depression, where psychotherapy or psychotropic medication is not effective. The other reason I bring up exercise too is because we know there's a lot of benefits, as I've listed below. But another piece, unfortunately, that we still struggle in our field is that there is still a stigma with mental health and seeking mental health services if you're experiencing depression or anxiety. And we find that more people are receptive to incorporating exercise first, maybe, than seeking a provider like myself. One reference I want to put here is the Physical Activities for Americans, the link for their second edition, which does provide some specific guidelines for individuals with disabilities. Another comment I want to make, again, I'm also not a nutritionist, but I do want to say that the National Center on Health, Physical Activity, and Disability does have a program. We call it the Mentor Program. And I want to bring it up because it's a free 8-week program that you can do at your own pace to help promote improved mental health and well-being. Now I want to talk a little bit briefly about self-care, and you probably hear this term thrown out often, take care of yourself, especially in the pandemic. And, you know, I always say it's so much easier said than done, but if practiced, it can improve well-being overall and mental health. And I can come up with many lists of hobbies and interests, and these are a few here that I've listed. I will comment that I've highlighted more or bolded more the ones that involve social support. Because as I stated earlier, when we talked about, you know, adjustment with the pandemic or even anyone adjusting to a new acquired disability, isolation can be something that's very high. So I would love to hear from those on the call if they have tips of how they've stayed connected during the pandemic that maybe others don't know. I also want to bring up the role of advocacy here. As mentioned, one of my guiding principles too is part of educating people with disabilities and others about advocacy. I always bring up to patients and families as they're learning to adapt is one of the things they learn too is about advocating for their own needs. And so it's important to know what your rights are and what your resources are in the community. So I've linked here just the Americans with Disabilities Act, and at the end of this presentation, some other resources to follow up with as well. Now I'm going to touch base briefly about some treatment options for the psychological piece here. And I want to put it in context. For many individuals, when a new acquired disability occurs, there is a period, again, for many people of grieving the loss and mourning the loss of your previous capabilities. And these are some signs of that grief response. But you do have to know when to seek help. And some of these that I've listed here are more in line with what we consider symptoms of depression or anxiety or post-traumatic growth. For example, if those feelings really interfere with your daily activities, or if you have repeated thoughts about death more than just fear of dying, and if you're experiencing recurrent vivid dreams or nightmares of traumatic events. One of the most common therapy approaches out there, which has been empirically based, is cognitive behavioral therapies. So basically, that's more of a problem-solving approach. You know, beliefs can be attributed by our thoughts and feelings, and that also dictates our actions. So the focus is really on challenging and or altering the underlying unhealthy patterns of thinking and creating new ones. Some of the tasks or interventions we might do here would involve skills training. There's also acceptance and commitment therapy, which is another area that's been evidence-based, which combines mindfulness therapies with cognitive behavioral techniques. So I want to just give you even one quick intervention here that I've utilized with patients often, which we call box breathing, Box breathing is something that was actually developed by the Navy SEALs to help reduce symptoms of stress and relax the nervous system in combat. But since that time, it's become widely popular. Really what it is that you're breathing in for 4 seconds, holding it for 4 seconds, breathing out for 4 seconds, and then holding it for 4 seconds. I'm going to just briefly model it and repeat it twice so you just get the idea. But you breathe in, 1, 2, 3, 4, hold, 1, 2, 3, 4, out, 1, 2, 3, 4, hold, 1, 2, 3, 4. Breathe in, 1, 2, 3, 4, hold, 1, 2, 3, 4, out, 1, 2, 3, 4, hold, 1, 2, 3, 4. There's other interventions similar to this as well. Some people have utilized a triangle, which is counting in for 3 seconds rather than 4. And I will say, I had colleagues out in New York that utilized this during the pandemic. They had created some outpatient groups that incorporated box breathing and some cognitive therapies to help address coping with the stressors related to pandemic. Another technique, which I won't go into detail, we call this is a 3-minute chill out technique. I will often use this with individuals that might have just increased stress or even trouble with sleep difficulties. I'm a big fan of 3-minute interventions, breathing interventions, because often that might be all that time the person has, or depending on cognitive abilities, what they might be able to attend to at the moment. Now I want to end about talking a little bit about mindfulness. And I'll explain a little bit more why I'm going to focus on this. But mindfulness, really what it is paying attention in a particular way on purpose in the present moment and non-judgmentally. In the medical literature, mindfulness is attention, awareness, and acceptance. And there's an 8-week program called mindfulness-based stress reduction utilized. When we talk about mindfulness, and especially since pandemic, I always explain to patients and families, there's just so much noise going around us. And our thoughts can be so focused on the past and the present, but our past and the future, but we need to focus on the present. How do we quiet all that noise around us? And mindfulness can be a strategy to cultivate that. You'll see that it's incorporated everywhere. There's many apps too, and there is research of its benefits in rehab populations. So I don't think it's a fad. It's been around for quite some time, and I do believe it will only grow in popularity. Why would it grow in popularity? I would argue that if you think about modern life, it's not mindful. And I don't know about you guys, but for me, even since the pandemic, I recognized before that I tend to multitask, but since then, there was a period of just always being on the go and doing multiple things at once. And society is just not set up for being mindful. Some mindless exercises you might have experienced. I know I've certainly been one guilty of talking to somebody and then I don't recall what they said because my thoughts were somewhere else. And I want to give the disclaimer, mindfulness is not a quick fix. You don't have to be Buddhist or emotionalist, and it doesn't mean that once you practice it once, you're going to be pain-free and that all your problems are going to be solved. In fact, when I'm explaining mindfulness to individuals, it's important to know that focusing on the moment, especially initially, might even result in a little bit of increased pain or discomfort. And I say that because you might be more aware of what's going on in your body or aware of your breath more. But again, the goal is that the more you practice it, the more you may be able to tolerate the discomfort, tolerate the emotions as well. There are a lot of different exercises here, but we always start with the breath and breathing exercises. For the purposes of timing here, I'm not going to go into a breathing exercise because I could probably do a whole different presentation on mindfulness. But I hope you get the idea of why I bring this up as a strategy as well. And I just want to point out that it's the small things that count. You know, could be trying to do maybe an hour of no technology, or taking 3 deep breaths before you enter a room or before you do a standing task. or participate in therapies. It could be even for some people a quiet car ride during a commute. And what I've listed here are just a few resources for anyone that is interested. And I also have my email address if you have questions as well. Thank you.
Dr. Paul, thank you so much. That was a fabulous overview of some of the techniques that are used and really some great tips for all of us. I love your comments about box breathing and do the little things. I think there's always this idea that improving, just like we feel overwhelmed by improving our physical health, that sometimes improving our mental health has to be an all or none thing, whereas there's some simple steps we can take and incorporate into our daily lives that can make a very important difference. So that was so helpful to hear. So feel free for the audience to post some questions in the Q&A, but while you are thinking of those, maybe I'll start off with a couple of questions for Dr. Paul. I loved your challenge to have us look at the positives. This is something that I've incorporated with my kids actually during the pandemic, and asking them to look for the yellow car, because you think there aren't that many yellow cars out there until you look for one. There are many. So I wonder if you could talk a little bit more about positive psychology and in particular, what rehab populations do we have that respond to this well, and how do we apply it better to our rehab populations?
Yeah, so I will give the disclaimer that positive psychology is not meant to really supplement the disease model of human functioning, but really just try to looking through things at a different lens, like you said. And it's a much broader field. And it's not just, also, I want to make the point, some people, when they think of positive psychology, they think it means happiness. It's not just happiness. It's really trying to transform the experience of suffering and to give a subjective sense of meaning and purpose. The mission of positive psychology is really to understand and then build on the human strengths. And so why I like this a lot, as I mentioned, we have guiding principles, and one of our guiding principles is to always focus on strengths. You need to acknowledge the strengths that the person with a disability has as well, and maybe utilize that as an intervention too. But really the three pillars are the focus on that valued subjective experience, positive individual traits, and even civic values and the institutions that support them as well. There's been more emerging research on this, particularly with brain injury populations or acquired brain injury. Some of the interventions they've utilized are things like even a gratitude journal to incorporate, for example, or even just having, the person with a disability come up with one positive trait and then have them try to incorporate that every day for a week to see if that is helpful too. There's also a lot of research on this with individuals with chronic pain and rheumatoid arthritis. That using aspects of your strengths and positive psychology can help with a reduction of pain as well, perceived reduction of pain.
Yeah, that's great. So you talked a little bit about the normal grief response with a newly diagnosed disability, these different stages. How do you know when someone is ready for that? And I ask this both from someone providing care, but also for all of us who probably have had a family member going through something like this. How do you know when it's a time to give a nudge toward those sorts of things and when that's going to be received well?
So a nudge towards, just to clarify, a nudge towards discussing resiliency and that the post-traumatic growth. Yeah, so you make up a great point, because one of the things I wanted to comment, and I recognize, the reason I wanted to give this presentation in this way and provide this information is because, like I said, a lot of our literature has been focused on the problems, and I don't want to minimize it. As a clinician, because I work on the inpatient units and individuals that, have acute chronic illness or acute disability, I'm very cognizant not to bring it up right away, not to bring up post-traumatic growth, because if I do, it can come across as me, a person who is able-bodied, as minimizing their experience too. So as providers, I think what's tough is that because the research is still emerging, there's no specific time frame to say that, after 1 year, this is a good time to bring it up, or after 3 years, maybe with an individual with a spinal cord injury. I often wait when I ask open-ended questions about maybe the support networks that they have or what they're doing. I might ask questions of that and wait for them to bring up that positive experience too. I'll share a great example is that I had a patient recently on the unit who actually, he was here on the unit for something else new, but he was a traumatic brain injury survivor. He survived a brain injury, a severe brain injury about 9 years ago. And so when I meet him and I'm talking to him, I'm just assessing his mood and adjustment now. And one of the things he was telling me is just about all the changes he had. For example, since his injury, he lost his business and he ended up having financial problems. Him and his wife and family had to downsize on their house. As they were trying to figure out, supportive networks, they even moved out of state for a while and came back. So he's telling me the story, but then he keeps focusing on, all this happened and it's terrible and it stinks. But if this didn't happen, I wouldn't be as close to my wife as I am now. I wouldn't be as close to my kids. I wouldn't have had this relationship. So that is an example of post-traumatic growth. And I also wanted to give the disclaimer. I mean, it sounds great and wonderful, but I also want to be cautious too, because with post-traumatic growth, it doesn't mean that, the depression is all of a sudden gone and you're great and happy and wonderful. Often individuals with post-traumatic growth may have new adversities that they're facing or struggles are facing too. And so it's still important to seek the support and services as well. The other piece, which I want to caution too, is that for some people, and this is again why I don't jump into post-traumatic growth too, is it may be seen for those individuals with disabilities as just another thing that they have to get to or have to, achieve. For example, it can add pressure too.
Mhm.
Yeah. So, and we do have, in the field, we do have inventories, a post-traumatic growth inventory that we use for assessment, which includes those 5 pillars, those pillars of personal strength, new possibilities, improved relationships, appreciation for life, and spiritual growth. So that could be something, one can do on the outpatient side. But again, I would caution doing it early and wait for the person to bring it up or even the family member to bring it up.
No, those are great points. And I think we've
Yeah.
all had experiences in working with patients,
Mhm.
family members, or someone who say something, who have incorporated these things so effectively that they will say things like, this is the best thing that ever happened to me. And I think,
Yeah.
it's easy to make an assumption like, how could that be? But understanding how incorporating some of those positive
Yeah.
thoughts can be so incredibly powerful,
Yeah.
and changing. I think it's
Yeah.
there's
I
a
was gonna
great question. Oh, sorry, go ahead.
Oh, no, go ahead. Go ahead.
There's a great question from the chat that's kind of along these lines about strategies for approaching rehab patients that do not have strong social and family support, that might be struggling with their new challenges, and how to help them navigate.
Yeah.
Speak to
Yeah.
that.
Yeah. So I think it's important because we do see a lot of families that may not have family supports or social supports. I would encourage trying to clarify maybe what their interests or hobbies are. And is there a way to connect to a community that might be similar with that? If it's a person with a new acquired disability, say for example, someone who has had a traumatic spinal cord injury, gauging their interests if they would be open to meeting with a peer support person. Because again, as we know, it's one thing to hear from somebody like myself, like I said, who's able-bodied and may have the book knowledge, but it's another thing to talk with somebody who has been through the experience as well. The other piece is gauging, even support groups for that as well, too. And again, I think it depends. Every patient is different. There are many patients I meet who tell me flat off, they're not a group person, they're not going to do it. And I say, that's great, that's fine. How about individual support or even outpatient counseling? That can be seen as support in one sense too.
Yeah, and we're very
Yeah.
fortunate here through the Rehab Network that we have some great peer mentoring groups and resources along those lines of people that want to provide that help and support. You mentioning the peer mentors made me think about the mentor program that you talked about in your talk, and how this could be used in a self-guided way. I wondered if you could talk more about who might be appropriate for that kind of that technique, and who could access that.
I think anybody with acquired disabilities or disabilities can do it. I will caution, we do have to put in context depending on the disability. There could be cognitive impairments, so you need to have a certain level of cognitive capability to participate, but that doesn't mean that maybe the caregiver or loved one or spouse can look into that as well and get some tips too through that program on how to better support their loved one. I know that I talked a little about families and coping with disability, but another reason I bring it up is because we know that the mental health and the adjustment is very intertwined. What we see in the research is that, if the person with a disability is experiencing depression or anxiety, often the spouse or the caregiver is as well, and vice versa too. So it's very important. If the person can't participate, I want to encourage them to look at that program themselves, spouse or loved ones.
Wonderful. It's a great resource. Going back to the idea of post-traumatic growth, are there predictors or common traits that you see?
Yeah. So as I said, it is still very much emerging. There's a lot of literature with acquired disabilities. There's even some literature, most of the literature has actually been with individuals who've experienced cancer or and patients with HIV. And there's some, I've seen one recently that was about individuals with spinal cord injury who participated in the Canadian Olympics or Canadian sports and showing an increased sense of autonomy. But one of the things we do know about traits, what they do say is, someone who has an openness to experience and extroversion. And that's probably because those who are more open are more likely to reconsider their belief system. And extroverts are more likely to be active in response to trauma and seek out connections with others too. But again, I don't want to give the disclaimer that if you consider yourself more introverted, if you get your energy from being alone, that doesn't mean you can't get to a period of post-traumatic growth. Yeah.
Very, very interesting and useful to have that insight, both to yourself and to those that you're interacting with. Let's talk a little bit more about resiliency. You talked about the common themes of resiliency, and I wonder if you can talk a little bit more, because they seem very distinct. They seem like very distinct concepts in different areas.
They are. And even though, like I said, there's no real universal definition, but there are some themes that are common in it. And I can break it down even quickly to, the personal competence or the psychological and dispositional issue. It's really that ability of your belief in your own abilities, your accomplishments, your determination. I'll even say what we call pre-morbid personality. So do you see things half glass full versus half glass empty? Do you believe you can get through this traumatic event? The other piece would be about like social competence, your belief in your own social situations and social adaptability, even ability to plan and organize daily activities. And again, we were talking just a little bit ago about the family support and cohesion and supportive networks. Those are also important to have. No matter what the disability, like I said, what we've seen in the research is that having support is helpful, and not having a sense of support or community can lead to that increased isolation and lead to poorer mental health outcomes. That's why I was stressing on it before when I brought up about the self-care hobbies and interests. And if there are people on this call who happen to be persons with disabilities or spouses or loved ones, I'm going to just ask if you want to type in. I'd be curious to hear, because I'm always looking too, and I'm sure other people on the call are looking for ways that they've found to connect too. I know a lot of people have done, the virtual stuff, Zoom, but there is a whole wide range of individuals who may not be comfortable with technology as well. So what have you done? What has worked?
Yeah. Have you noticed any, much like we talked about the traits associated with success and with positive psychology and post-traumatic growth, have you seen anything that helps predict resiliency in that way?
Well, things that predict resiliency, like I mentioned, a lot of it does have to go back to the social supports and the attitude and belief as well that you can, get through this event, that this disability is not all of who you are. It's just one aspect of you as well. Yeah. And it's a little hard to explain because, like I mentioned, there's a lot of different models of resiliency. There's one model for brain injury. There's a couple of different models they have for spinal cord injury and individuals with chronic pain or burn. And even in that area, the research is still emerging. I just wanted to make a point again. I know that this term is used a lot, and we know that there's something there. And we know that many individuals that have an acquired disability do adjust to it and do have a positive adaptation. We want to know more what that is, like you're saying, what are those exact traits? And it's different for everyone. It is, but there's ways to try to cultivate that. You know, I mentioned before that, some theorists talk about that it's a more trait-like, and I don't really like that, because when you say trait-like, it just says that's it. It's the personality. You can't change it. And that's very different from what I'm doing. I'm trying to work on changing your thoughts, behaviors, feelings, actions. I'm trying to work on skills. I'm trying to work on understanding your definition of acceptance and seeing if you would even be open to considering another possibility. And that's sometimes how I frame it to patients. Would you be even open? Would you just hear it out? I don't want to force it on anybody. Again, don't want to come across as minimizing it, but sometimes, particularly with acceptance, when we can learn to be okay with where things are at, sometimes that can help ease the distress.
Yeah. There's another great comment in the chat that knowing the current pain or situation is temporary and it'll change, but how to wait and have caregivers wait for that change in pain or condition situation.
It's an issue, which is why I said, I know in talking with coping strategies, I brought up more about the psychological piece, but like I've mentioned, you can't consider adjusting to disability or adaptation to disability without looking at the big picture or the social constructs and the contextual factors. I'll give just another quick example. I had a patient many years ago who, when I was working in another setting on the outpatient, a person who was a stroke survivor and unfortunately, had some marital discord. So he's no longer married. He lived alone in an apartment. And the physiatrist asked me to see him because he was experiencing high levels of panic and anxiety. And he was about 5 years out of his injury, post-injury. So when I meet him, as I'm gathering and assessing what's going on in his symptoms, one of the things when we talk about the triggers and the times that these feelings of anxiety or panic occur was that they were occurring more in the evening because he had waiver services, and the waiver services stopped early in his eyes about 4:30 in the afternoon. And he had no one there to help to help provide care from 4:30 till 8 o'clock the next morning. Again, putting that in context, that would increase anxiety as well and be a product of it. So not only were my interventions focused at that time on strategies to promote relaxation, but also getting his permission to talk to his caseworker, asking the physiatrist to maybe write up a statement to suffice, the reasons for increased waiver services, which he was able to get, which was nice.
Yeah, it's and that kind of segues into this important conversation about access to good behavioral health support, right? In addition to access to other types of healthcare support. There's a question about chronic pain support groups or therapists and how to find those in your community.
There are a lot. I'll say for the chronic pain, we do have psychologists over at our Shady Side Center, and I'm happy to provide information. If Dr. So you want to even give them my email address, I'm happy to provide resources or send that through as well. We do have a large healthcare system here, and we do have many providers in different departments. So, and these are strengths too.
Absolutely. Yeah. There's pain psychology on the Oakland campus as well. In our department. So lots of resources. You mentioned, so when we talk about access, so many of our patients have found the virtual platform to be helpful. And some, as you alluded to, really are uncomfortable with it, particularly for behavioral health type services. So can you talk a little bit about your experience with that over the last 2 years now?
I feel like it's been more, just in my small, narrow view, it's been, in terms of increasing access to healthcare, I think it's been wonderful because, like you mentioned, many individuals access to transportation, or if they live out of this area, out of the Oakland, Pittsburgh area, and maybe in an area that's 2 hours away with limited psychological resources or medical resources, using the virtual platform has been great and wonderful. I do still think it's a learning curve for some people. I think, what I've seen in my small lens is that more of the older individuals who may not be comfortable with it with learning about it. So what I've done as an intervention is I've even pulled in on the inpatient unit, maybe gathering OT to see, you know, if the person is interested or the family is interested in maybe learning more about technology, can we incorporate that as maybe a goal so they can be able to access treatment later? Or even using, again, some of the resources like, you know, our Center for Assisted Technology, you know, could be a way to help with that as well. Another thing that I've seen too, it might be harder, again, talking about access, is individuals who may have financial restraints too. You know, I like to think even in this day and age, you know, we might assume that everybody has a cell phone that has the internet or Zoom capability, or even email or Zoom platform, a computer, but not everybody has that too. And again, just trying to be inclusive as well. You know, it may not be appropriate for some individuals too, depending on the disability. You know, somebody with a more severe brain injury, you know, doing telehealth services is not appropriate. It's hard to gauge with them at that time. It could be just another external distractor, for example.
Absolutely. Or the setting in which to have a conversation. So yeah, that's great. Well, this is such a wonderful dialogue. It's been a pleasure to learn from you and hear about these topics. I appreciate everyone who joined us today. I'm going to turn things over to Andy to close us out today, but thank you for such a great discussion.
Thank you.
Yes, that's all the time we have this evening. Dr. Soa and Dr. Paul, thank you so much for such an informative presentation and discussion. For anyone who had a question we were unable to get to this evening, or if you have any additional questions, or if you'd like to learn ways to support the Department of Physical Medicine and Rehabilitation, please contact me at raz37@pitt.edu. Dr. Soa and Dr. Paul, thank you again. And to everyone who joined us, please be on the lookout for future sessions of Rehab Reels, and have a good evening.